It really is my pleasure and privilege to introduce our closing speaker, Dr. Sandra Hernandez. Dr. Hernandez is a physician. She is the Chief Executive Officer of the San Francisco Foundation, which is a community foundation serving the greater San Francisco Bay Area. She was the former Director of Public Health in San Francisco. She is a practicing physician, which is, I think, also really important to know about her. And she has served on many, many boards and many, many committees at the federal level, at the state level. She's going to interrupt me. And best of all, I get to call her a colleague and a friend, so Dr. Hernandez.
Thank you, Ignatius. I appreciate that. We said we were going to keep it short. First of all, let me just say it's nice to be here. Oops, let me do this. Yep. I got here just as Dr. Harding was finishing your Q&A before lunch. And just by way of segue, as I was sitting in the back of the room listening to the conversation about what self do you bring, and actually somebody even referred to being schizophrenic, I thought it would be important to share a very, very short poem by a Chicana poet named Bernice Zamora. She's from Colorado. Some of you have read her poetry. And when I was in college and you're sort of figuring out, are you Chicana, are you Latina, who are you? This poem had great enlightenment for me. And of course I went on and majored in psychology, so it even had more relevance. And the poem goes like this: "You insult me when you call me schizophrenic. My divisions are infinite." So I thought if I'd known what the segue was, I might have used that to start this talk. But yeah, you insult me when you call me schizophrenic. My divisions are infinite. Well, it's nice to be here today. Ignatius asked me to talk a little bit about my experience in collaboration and really my path, such as it's been, in sort of a curious way of trying to understand how to build healthy communities. So that's what I'm going to talk about today. He mentioned I'm CEO of the San Francisco Foundation. I went from being the director of health and running acute care hospitals and long-term care hospitals and mental health clinics and in a variety of contracted services with organizations providing all kinds of health and mental health services to running a community foundation. And a lot of people would ask you, why did you do that? And long and short of it is that I had been in the health department in a variety of different capacities. So I started there doing HIV work, really trying to build a non-institutional delivery system for people with HIV very early in the AIDS epidemic. And then went on and ran all the public health programs, all the prevention programs, became the county health officer. And then when I got to being the director of health, there were many nagging notions that I knew very little about as a trained internist. I came to San Francisco right out of medical school to do my residency in internal medicine at San Francisco General Hospital. I wanted to be in a county hospital. I wanted to be in an urban setting. And I knew very little, really, about communities and how communities work and how communities came together to solve problems. And here we were in the midst of the AIDS epidemic. So when I came to the San Francisco Foundation, it really was with this notion of needing to understand a lot more about poverty, needing to understand a lot more about educational attainment, and particularly the role of early childhood education. I was extremely fascinated with the environment and environmental science and environmental health and how the environment impacted people's quality of life and health outcomes. And I also had been really grown up. I was a young doc at San Francisco General in the Mission District. I knew a lot about how San Francisco worked at the end of my health director role, but I had a sense that there was a region, and I didn't really understand how the region worked. And so all those things made the opportunity to come to the San Francisco Foundation for me mostly an extraordinary learning opportunity. Actually, I told the board, I'm not exactly sure why you want a doctor to run a community foundation, and they sort of said, well, we don't really want a doctor to run the community foundation, we sort of want you to run it. So With that, we are a place-based community foundation. We do a lot of different things. Most people think of us mostly as grant makers. That's really not how I think of ourselves mostly. And of course, we take a lens at disparities in all the areas that we talked about. And because we all have all these different selves, my partner of 18 years is a practicing artist, so I can assure you that arts and arts participation and the cultural expressions that are so important in our communities are never out of my mind, and they're also actually part of the San Francisco Foundation's mission. So I was a primary care internal medicine trained physician when I came here a little over 25 years ago, and loved primary care. Actually still love continuity care, and as Ignatius mentioned, I still see patients. Actually, I'm doing this today instead of seeing patients, but it is sort of the place where all the policy work and all the analysis, you sit down with an individual and actually are in relationship with them. And having come up doing that principally through the lens of HIV disease, that was really a disease that transformed how we thought about a physician and a patient relationship and how we thought about that individual in the context of their community. So I really became a primary care trained internist into a kind of perpetual student and became very interested in cars, parks, urban design, housing, land use, and as I mentioned a lot, an environment. I'm going to talk about a few of those things as they kind of evolved in my career. So one of the things I learned very early on is as a physician, you know, all the training you get as a physician to go into public health or to go into the practice of medicine is take a good history, right? Take a good history from the patient. So think about that in a community context. Well, take a good history really does imply you absolutely have to listen to what it is the community is telling you. Because we as experts or technicians or clinicians tend to come with our lens for taking what we heard and trying to figure out how that constitutes a problem that we are going to intervene with. And I think one of the things, again, I learned dramatically in working with AIDS patients and with all the patient population that we see at San Francisco General Hospital is you can take a great history, and if you develop a plan that does not fundamentally address what they need from you, you're not going to have a successful relationship. And so I try to define the terms in the problem in the broadest terms. Try to think about whether we're asking the right questions, and most of all, knowing what you don't know, which I can tell you I've been humbled 25 years into my career. Getting the right data. We tend to get data, and you know, in a physician relationship, we order a bunch of labs, and we see the labs, and we say, well, there's abnormal liver function, there's abnormal renal function, but what they came to talk to you about had nothing to do with their kidneys or their liver. And so, what data is actually going to help you design a plan that's going to be effective to work in a hand-in-hand relationship? So, getting the right data, getting help, finding the right partners, which has been the theme of your work for the last 2 days, and then finding the wins among them. So I want to talk about this little situation because I was quite struck when I was director of health, even then, and that was before we had the kind of financial constraints that we have today. Always looking at data on costs and utilization, and of course, we had what we referred to as the frequent flyer club at San Francisco General in the ER, and these were patients who everybody knew by first name. They would come into the surgery service, sometimes they go into the medical service, sometimes they come into the ortho service. They'd utilize a lot of specialty care. We'd always see them through the ER. We'd clean their wounds, we'd stabilize them, and then we'd do this amazing thing. We'd give them a voucher, and we'd say, here's 3 days at that really, really horrific SRO hotel. And by the way, can you take these antibiotics, make this outpatient appointment, clean your wounds? And we would wonder why about 4 days later, maybe 5, they'd come back. They'd taken 2 antibiotics, not the complete set. They never made it to a medical home. They never saw a primary care provider. And so we looked at it as a lack of care coordination and not having a medical home and poor compliance with meds and high-cost patients. And then I met somebody who was in the homeless arena in a very political sphere. So this was in between Mayor Jordan and Mayor Brown. And I knew and had worked with the homeless czar for Mayor Jordan. And I thought, this is actually somebody who could help us figure out how we actually find a way to stabilize these people in homes. It was just a wild idea that the 3-day voucher to go to an SRO hotel was not going to be successful. So I went to Mayor Jordan just before he went out the door, and I said, I want the rec, and I want Mark Trotz to come to the health department and do housing. And he said, you run the health department. I have a mayor's office of housing. I said, I know, but I think Mark can help us figure out what to do with, and it's one rec, and by the way, I want you to pay for the rec. So I got the expertise, I got the position, and I had no idea, zero, what we were going to do with it, right? It was a complete and utter lark. What I knew was that the way we were conceptualizing these high utilization patient population wasn't working because we had tried numerous clinical transformations and care coordinations. So a couple things happened. Met Mark, I got Mark. The Corporation for Supportive Housing was an organization out of New York who had this notion of providing permanent, affordable housing for complex, chronically homeless individuals. I thought, that's interesting. I wonder if we could do supportive housing and find a way to pay for it out of what we weren't spending in the ER. So I got the leadership, I got some technical capability, and then we decided, I went to the surgery service and I said, let's take the next 3 patients that we're going to discharge with a 3-day voucher to an SRO hotel and actually ask them what would be helpful. And Mark sat in the room, and long and short of it, we put a bunch of people who you might imagine could be helpful in this. None of them, by the way, related to ER docs, utilization nurses, even discharge planners, even though that's mostly what I had on payroll. So here it is 15 years later, and I talk about this partly because I literally had no idea what this thing would look like when we kind of put these pieces together and hobbled them together. And what's happened over 15 years is the development of the Direct Access to Housing program. It's developed about 600 permanently housed individuals in affordable housing, developed this fabulous notion of screening in. So instead of saying, you have to be clean and sober, and you have to be on meds, and you have to, this one actually has a very low threshold to get in. Actually, we want you to get housed. We'd like you to get into drug treatment. We'd like you to make your outpatient appointments and the like, but that's actually not the core criteria. And you can see what some of the outcomes have been from that program. And I really share that story in part because I knew nothing about affordable housing. Didn't know how it was financed, didn't know what the sources of funds were. I was very familiar with Medi-Cal. I knew how to bill Medi-Cal. We knew a lot about FQHC. We eventually wrapped some FQHC around this. But my point being, not knowing what knowing what I didn't know, trying to find somebody who I thought had the value set as well as the technical capabilities to do this. And I remember very vividly telling Mark, he came over, he said, what am I going to do? I said, well, first thing you're going to do is write your own job description. He said, I'm going to write a job description. I go, right. Then he said, am I going to have any budget? I said, write a job description, then we'll go from there. So really, I don't take any credit for this. This has been developed over the years with great leadership from Barb Garcia and Mitch Katz and Mark Trotz. And a lot of different nonprofit providers have made this model work. And would I call it a collaboration? Mostly I would just call it a way of thinking about what those patients needed that our ER really was not providing them. Is it, do they now have medical care? Are they getting utilization at the right time in the right place? Did we reduce costs? Yes, yes, and yes. But mostly we've created homes, places where people bathe regularly, eat regularly, where people are now peers, and living in community. So really an area that I knew nothing about, and over the years become more and more interested in how housing and what housing looks like, how that has implications for community. So I follow a little bit the Institute for the Future's notion of what's the future of healthcare and what is the future of wellness. And they talk about the urban wilderness, which I just think is fabulous, right? Partly because, we read about, the deficit of people being out in open space and being out and appreciating Mother Nature. So this concept of an urban wilderness, I've been fascinated with and done a lot of reading about. And of course, if you do that and you run a community foundation, you're doing a lot of place-based work, you start to think about cities and neighborhoods from the point of view of what is the way that this place defines who you might be and how you might be in the world. And of course, here's other things that we know about the consolidation of people into urban spaces and into cities across the world globally. But it strikes me that what's true globally is also true right here in West Oakland and in Bayview and in other areas, Richmond, places where we work. So I became very interested in this question about how do people get around? Partly because, again, wearing all the different hats you wear. Some years ago, I have a lot of family who lives in Southern California, and I seem to only go there for funerals, quite purposefully, I fear, in part because I go there and I get extraordinarily stressed out with gridlock, right? I mean, the traffic there is just stunning to me. I went to visit an aunt, a tia of mine, who had end-stage Alzheimer's, and I rented a car. I was going about 20 miles from the airport I flew into to her home. I figured that would take me maybe 45 minutes. I flew in at 10 o'clock in the morning, and an hour and 50 minutes later, I still wasn't there. Right? And I had planned my day around spending the day with my aunt. And so then about 2 weeks later, my aunt passed, and my entire family, of course, congregated in San Bernardino, thereabouts. And I drove my entire family there, and in driving through there, I thought, haven't seen a park, and got off the freeway and saw absolutely one fast food restaurant after another. And I thought, wow, what, so contrast with living in an open space where you're about 5 miles from the ocean, about a mile from the bay, and so this notion of place and transportation, and then kind of taking the realistic demographics that we're about 7 million people today in our 9 counties and are going to be about 9 million people in about 25 years. How do we plan for and accommodate 2 million more people over the next 25 years? One option is to move to rural New Mexico, which I've seriously considered doing, but in fact, this is an incredible opportunity for us to plan. We spent a lot of time sort of trying to understand transportation costs, and I was struck by this notion that very low-income families can spend close to 1/3 of their income to own a car. And if you figure that they're spending 70% of their income, some of them, to be sheltered, not a lot left for much of anything else. And so this notion about whether you could reduce commuter-related stress, which I could personally feel, this notion of all of us trying to work to see how do we get parents more engaged in public schools. My cousin in Southern California commutes an hour and 20 minutes to work both ways, coming and going. Leaves in the morning before dark, comes back dark, and we want them more engaged in schools. And of course, we want people to be more physically active, and a lot of people have written now about the benefits of social capital. So I started to think about cars, and a lot of work has been done now as the state of California prepares to reduce carbon emissions because of AB 32 and and SB 375. And what remarkably happened is that a lot of federal transportation dollars have come into the state of California. And those transportation dollars give us an opportunity to look at transportation hubs and to think about how we build around transportation hubs to achieve the capability for density housing, but also to think about how people can get to and from work and what those spaces around transit looks like. And so an extraordinary collaboration with a number of different partners have come together. And they're called the Greater Communities Collaborative. And they did something quite remarkable, which was they got the Metropolitan Transit Commission to commit to a $50 million low-income affordable housing fund around their transit sites. Right? Because in the carbon emissions bill that was passed and signed into law by Governor Schwarzenegger, there was actually a requirement that people begin to plan around transit hubs with the notion of looking at land use, affordable housing, and open space. And so these dollars now are beginning to be loaned to nonprofit housing developers. They're looking at how they build density housing, think about protection of open space. They're acquiring land because there's huge development pressures for land. And of course, everybody likes the leverage. Philanthropic institutions have invested in this fund, Ford Foundation, Living Cities, San Francisco Foundation, and others. And this is now a $50 million fund trying to provide affordable mixed-use housing around transportation hubs, which the Transportation Agency will be heavily investing in with federal dollars. The MTC also passed the first ever planning rule that would require local planning by citizens that are in these communities to think about what these transit hubs look like. And what I would say about those is these comments, which is governance is messy, right? Who governs a nonprofit fund that's funded with federal transportation money, comes through the MTC, is being developed by nonprofit developers, has foundations involved in it, has large individual donors involved with it. How do you govern something like that? Right? Really challenging governance questions. The mixing of money, the notion of using transit money to plan for affordable housing was an absolute wild. The head of MTC came to the first press conference when Tenderloin Development Corporation was talking about acquiring a piece of land that's currently a parking lot in the Tenderloin and building 37 units of affordable housing with a fresh market underneath, which is about 3 blocks from a big transit site that's about to get a lot of money. And the notion of transit money to do that is sort of the kinds of thing that you have to sort of say, who else is interested in the goals that we have around these sites? This is a great quote from Einstein. One of the things that collaborations do, and certainly multi-sector collaborations do, is make things very, very complicated. Right, but I love this quote. It says, our scientific view of the universe, and you could say of communities here, should be as simple as possible, but not more simple than that. And that really acknowledges that we're always going to be operating in a place of a lot of unknowns where different people will have different influence over funding, but the ultimate idea here is that we've studied disparities for health around individual characteristics for a long time, right? We had, Healthy People 2010. We've documented ad nauseum asthma rates, obesity rates, diabetes rates, rates of tobacco use. We've correlated it to income. But we haven't really thought if we're going to invest into thinking about what places look like when they have a lot more population, what would be the measures in public health or in health outcomes broadly that we'd want to follow? What would we measure? And turns out that there's been a lot more research on this in the UK and in Canada than there has been in the United States, although there are researchers at UC Berkeley and elsewhere, Colorado, who are looking at this. But I think this whole concept of what are the concepts of well-being that place and space can create? And they don't, the conceptual models for how you measure that and how you define that, we just need to do a lot more work in. I give you these because these are 3 things that I've been toying around with. I'm not a transportation expert. I'm not an affordable housing expert. I'm sort of barely an HIV expert anymore. Right? One of the things that I think has been interesting about being open to collaborating deeply across sectors has been this notion that you're willing to go and learn enough about that sector and enough about those mindsets to try to figure out what these common wins are. And one of the things that I've been very struck with, and I am by no means a social media expert. Actually, they were asking me if I tweeted, and I admitted that I don't. I barely check email. But there is certainly an astounding capability happening around citizens' ability to collaborate with us on things that are matter to them. And I'm, without becoming an expert in any of them, these are just sort of the three that are on my list right now that I thought I'd share with you because they represent sort of how my curiosity takes me to look at what the next piece of this work might be. I was struck by talking with one of our participants from the conference who's an advocate, a recovering lawyer, and majored in psychology, urban planning, and neurolinguistics, right? I'm like, wow, I want to sit and talk with you. Dr. Burke in Bayview wrote this article that you might have seen in the New York Times Magazine about, the neuroendocrine basis of stress and stressful lifestyles, and this concept, which I think Dr. Harding was talking about earlier, about repetitive stress and how does that manifest itself in our neuroendocrine biological kind of pathways. And so one of the things I would encourage all of you to do as you think about building more multi-sector collaborations is to read and to talk with people who are likewise coming out of a professional silo and who have an interest in those things that you have expertise in. But one of the things that runs through all three of these is that the people who hold expertise are not necessarily the ones that are best able to solve the problem, right? I mean, that's probably the most humbling thing of being a practicing physician in a big urban center, trying to run a community foundation and think about how you actually build strong communities, right? Is that the notion of who holds the expertise, who holds the technical knowledge, who manipulates the data, who posits the questions, is really being quite dramatically transformed right around us, right? And the only saving grace I have is that I have an 11-year-old daughter who is just dying to show me all the social media that there is out there, and I'm actively constraining her from doing that today. But that is an area, and if I were to say, where are you remedial, Dr. Hernandez, that's definitely an area that I'm remedial. But these are just examples of areas of places where I'm curious about, in the AIDS epidemic, patients would develop their own clinical trials in community, right? We did community-based clinical trials. They weren't required to be part of the hospital. And in environmental projects, people are collecting their own data and doing their own community surveillance and their own epidemiology to understand what's happening in their environments. And that, to me, is one of the most transformative things in thinking about how we build strong communities going forward. And again, if you don't sort of see yourself as a perpetual student, but as an expert in a particular area, I think you lose the capabilities to work across collaborations when you go and say, I really know nothing about affordable housing, I know nothing about transportation, I know very little about X, Y, and Z. I certainly have an expertise, I have a training, I have some resources to deploy, but fundamentally, these are the kinds of transformations that I think are available to us if we're willing really to get ourselves out of our comfort zone and our expert zone. And so I spend a lot more time in things that I know nothing about, increasingly, and a lot less time in things that are my comfort zone. Mind you, I continue to learn from patients because the things that they posit to you make real what you're trying to do and problems you're trying to solve. I was at the Jewish Museum the other day seeing an exhibition, and I was really struck by, this is at the Jewish Museum, it's the Gertrude Stein exhibit, which is closing, by the way, at the end of Labor Day. And I thought this was just such, it captured my notion that she says a writer should write with his eyes and a painter should paint with his ears. To me, it said a lot about whatever is your form of engaging community and solving problems and working in community, you actually need to use some senses that you have not fully evolved. And that, to me, would be sort of a lasting thought as you think about going and doing collaborations that are multi-sector, that are complex, that have very sticky governance issues, and that the tools that individuals and citizens and residents are beginning to use are tools that are really powerful for engagement if we're willing to kind of take our sensory capabilities and expand them in areas that, and by the way, I don't write and I don't paint. But again, and of course she was a very prolific writer and wrote a lot of plays and wrote a lot about the war. So I was very struck with this particular piece. I want to end with one final thought, and then I really do want to open it up to questions or comments. My daughter asked me the other day if I'd ever been on stage to act. And my daughter, by the way, is an actress and sings and is very lyrical and writes music, and I don't sing. And I said, well, I've been on stage, does that count? And she said, no, that doesn't count at all. Have you ever stood on stage and acted? And so I said, no. And she said, you know, I think you ought to take an acting class. And I could feel my neuroendocrine system get really hot. My palms got really sweaty. And I was like, an acting class? I don't think so, Maya. It doesn't sound like a good idea to me. But, and you know, not that you need practice being on stage, but I think this notion of those things that make your palms sweaty and make you kind of have a neuroendocrine response are maybe areas that would allow you to be more effective at what it is that you're trying to do, which is to be a full human being, to continue to read, and to continue to challenge your intellectual capabilities around those things that motivate your values. And all of you sat in this room today around a set of issues, whether it's violence in our communities, whether it's suicide, whether it's you know, our dropout rates. I mean, there are many, many ways. And you notice I did not have one slide that described one chronic disease. We have framed these questions as chronic diseases over and over and over again, as if we continue to codify them within our communities. Not that it isn't important to know what they are and that they exist, but we've documented them. And so in many ways, one of the things I'd strongly encourage you in your collaboration is to write those stories of inspiration, those wins whenever they happen, you know, and all those things that happen, that win, that make a big impact. And by the way, GCC, we've got, you know, $500,000 invested. There's a $50 million fund. I actually don't know whether any of these transit hubs are going to look different than they do today. Right? Actually, I don't even know what the right yet public health framework we should put on what a resilient community looks like. You know, should we be tracking obesity rates there? Should we be tracking cortisol levels there? Should we be tracking sense of happiness? That's kind of my final thought, is that I haven't registered yet for my theater class. But you know, someone who's been 25 years trying to think about how communities get healthier, those are some of the thoughts I leave with you today. And I'll open it up for any questions or comments anybody has. Thank you.
It's interesting that you were mentioning the supportive housing program. A couple years ago, I was working with Catholic Charities doing supportive housing for people that were formerly homeless. And it came back to what you just said. Basically, we began to provide housing for them, stable housing on Treasure Island, and all sorts of supportive services. But then what happens? Were they happy? Were they healthier? what was the quality of life like? It's like this continuum, the circle, we keep coming back around to the same piece. And the thing you just said about being happiness, do we measure cortisol rates? Do we measure how happy people are, how healthy they are? How do we really do that piece? That definitely resonates with me in many respects. So that's, I guess, the rhetorical question here.
Yeah, it's interesting. I was on the board of the Corporation for Supportive Housing for many years after they came into San Francisco and helped design this program and really worked with a lot of the nonprofit housing providers. I'll tell you that one of the cities that they worked in was in Minneapolis. And there was always during the winter a half a dozen to a dozen Native American people who used to freeze to death while they were on the streets. And in a particular ravine area where there was a lot of drinking that would go on, people get intoxicated, it would freeze, and they would die of hypothermia. And Corporation for Supportive Housing, very early when I went on their board, were taking us through some of their sites and some of their programs. And what they built in this particular physical place, about maybe 500 yards from where a lot of these deaths had occurred, was a supportive housing residential program all on one floor. And they got a city waiver so that when you actually went into these rooms, where the beds sat in these studio apartments, they put glass on the top and on the sides. So actually, as you were lying in bed, I think, you were looking outside under the stars as if you were sleeping outside, right? And that sensibility around what would it take, first of all, to have somebody come into supportive housing, have the trust to be able to do that, how to do that with a cultural nuance that would work, was something I was very struck about about CSH and their work across the country. And it's a mixed group. About 2/3 of the folks who've gone to this housing take a number of different indicators, and you would say it's been a success. I think I have a basic tenet, which is that the vast majority of people do not want to be institutionalized, right? I mean, it's something I learned very viscerally during the AIDS epidemic, that we could have kept people in acute care hospitals, and that could have been the way we responded to the HIV epidemic. And given how quickly people were dying, the age of people who were dying early in the AIDS epidemic, the notion that we were trying to get people into community was something that I learned very, very, very early on as a clinician. And this is somebody who's very comfortable in a hospital, right? And so I think this notion about being deinstitutionalized and being within community, and therefore, a supportive housing program to another can feel a little bit more institutional, a little less, depending on what it looks like, how many resources it has or not. The one thing I would tell you is that I have a friend that lives in New York and comes and visits, 2 or 3 times a year. And over the years, she said to me, it feels like there's less homeless in San Francisco than there were 8 or 10 years ago. And the fact of the matter is, after direct access to housing happened, Mayor Newsom came in, and that was his big campaign, and now his mayor's office of housing does all the supportive housing in addition to the health department. So we're doing more of it. It has frailer services around it. The resources to keep those services are constrained. Is it better than being in the emergency room? We'd have to ask them. But I think that's been one of the big motivations, is sort of thinking about how do you create community externally and give people a different role in their life besides being seen as a patient revolving through psych emergency or medical emergency rooms.
Well, what I want to say just keeps changing as you keep talking. I think where I'm landing at the moment is I really find your presentation inspirational for a couple of reasons. In that you took on a situation, had no clue how to do it, brought all your expertise, and then invited people that you knew had expertise, and then handed them the ball and said, write your job description, how do you want to play? So really, it's an example, I think, of a tremendous empowerment and also tremendous risk, and seeing a challenge as an opportunity and wearing the hat as opposed to seeing all the obstacles. It seems to me, and hearing you, that you looked for all the opportunities and then found the key players, gave them the power to participate to the level as fully as they needed to, and brought in great partnership and produced extraordinary and unpredictable results. And so thank you for doing that.
Yeah, I appreciate
and
that.
sharing it.
You know, I think the most important word you said there, in some ways, is how you think about risk. I think the biggest risk we face today is trying to do things the way we've always done them, right? And in part because there simply aren't the financial resources to do things the way we've always done them. And so, you know, people will say today at the foundation, you know, nonprofits are really have their backs against the wall. They have declining government contracts. The demand for services is growing. And, you know, I view that as an incredible opportunity to break through very siloed funding, very siloed programs. Community foundations used to be very siloed. Here's your arts and culture money. Here's your community development money. Here's your education money. Here's the health money. And you can't really do business that way anymore, whether you're running a foundation, whether you're running a public health department, whether you're running an academic department in a public institution. This is a period of time when innovation, and will be fueled dramatically by some of the things we talked about, should be making us take a lot more risks. And, you know, one of the beautiful things about being in a foundation is they say, you know, you have this risk capital. You know, I think that maybe one of the things by virtue of being, you know, first generation immigrant to this country, the notion of risk is really interesting, right? I mean, my grandma described getting on a train to go visit my dad who had tuberculosis in Denver, didn't speak English, never been in Denver, had no idea where she was going, and described it as if she was going down to the corner store to buy milk, right? And so the notion of risk is one that I think we all have to explore within our own temperaments and our own history and our own culture. As we have more and more immigrants being part of the solution of what our communities look like, a more multicultural community, I think we have to think about risk differently. And so for me, I didn't really think, what if this program fails, right? I mean, you know, we kind of gave it some political cover until we could figure out what it really was. But if you know that what you've done, you know, 1,500 times hasn't given you much change, it would be time to try something else. And that's kind of the spirit in which I think about risk. That and, you know, maybe, you know, instead of Alzheimer's, I'll just have really bad ADD. But, you know, I really do think there's an element of this that requires that we rethink how we assess risk and what we're willing to undertake. And, you know, so many people who hold on to power, you know, I kind of look at them and go, well, what's the risk of sharing power? What's the risk of sharing knowledge? Well, you know, everything is open source now. There is no private knowledge. So I think the whole concept of risk is really changing quite dramatically, and how knowledge is built and how knowledge is shared and how it's leveraged is really changing. And you know, I find it, you know, a totally non-boring life to think about how you build strong communities as one person who has a particular set of skills and a particular set of knowledge, and kind of who do you bring into the room to help build that community. So, interesting question about risk. I would stand between you and a Friday, which is the last weekend of August. So thank you all for being a great audience, and thank you for all the work you do.